And then we went to watch Mission Impossible.
Hello everybody, we're going to get started. So thank you for joining us at the monthly University Seminar Programme. We have two fabulous speakers today. Just a reminder that after the talks today, we will have cake in the collaborative space just around the corner, so please come and join us for that. And also, if you are online and joining us, because we record these sessions and they're found on the webpage, on our seminar webpage afterwards, if you're online and you want to ask a question, please wait to the end of the talk and either put it in the chat box or put your hand up and we will come to you when we spot you. So thanks everybody for joining us. And our first speaker today is Alicja Rudnicka, who is going to talk to us about eye disease.
Yeah.
So,
yeah, using the eyes.
Thank you very much, Alicja.
No, that's fine. Can everybody online hear okay? And if I just pop up my slides, is that all visible okay? I'll just get that out of the way. I need to get a thumbs up. Let me know. Let me just have a look. Yeah, thank you, Irina. Oh, Irina, do you want to ask something? Is it okay, hopefully? Let's just check.
No, sorry. Press the wrong button, sorry.
Okay. I thought maybe there was a problem. But I'll put the chat up ready for next time. Okay. Right, let's just minimize that and I'll just put my pointer on there. Well, thank you everybody for coming who's here today. And for those of you who are online, it's lovely to have this opportunity to come and talk to you about some of the work that we're working on in PHI that we think is very exciting. It's called Automated Retinal Vasculometry Predicts Circulatory Mortality. So this is what I'm going to talk about. I'm going to talk about what we mean by automated retinal vasculometry system, which is called QUARTZ, which we've developed with Kingston University. I'm going to outline what it measures and how it measures it. Then we're going to look at some just associations with those retinal vasculometry markers with cardiovascular risk factors, and then look at how retinal vasculometry can predict in the future events, particularly circulatory mortality, stroke, and coronary heart disease. And then we're going to start thinking, well, if this tool is useful, how could it be incorporated? How could it be used for circulatory disease prevention potentially? So just a quick snapshot from the British Heart Foundation about how they're now sort of talking about together heart and circulatory disease. And this is the sort of PDF summary of theirs from April this year, saying there are about 7.6 million people living with these conditions. About half of us at some point in our lifetime will have a heart or circulatory disease event or period of suffering with that. And twice as many people are living with these conditions combined than there are with cancer and Alzheimer's combined. Annually, it accounts for about 168,000 deaths, of which 48,000 are in those aged under 75 years. And as well as having heart and circulatory mortality, 80% have at least one other health condition. And although numbers are falling, because treatment's obviously getting better, but it still remains a considerable health burden. So I'm going to tap into a little bit about the NHS health check, because we had a meeting earlier this week with the Office of Health Improvement and Disparities about this particular pathway. And that people are invited now to attend at a particular age, given here 40 to 74 years, are invited to participate in the health check, which I'm not going to go into great detail here, but it has sort of usual measures of age, ethnicity, blood pressure, cholesterol, sex, to get a risk assessment, and then some advice about lifestyle modification if required. But also there's a potential pathway to then move into clinical risk assessment, especially if people are suspect having diabetes or high blood pressure, and so there are more clinical assessments that are done. And then risk management for those individuals, including medications, lifestyle, and CVD risk over a certain amount, consider adding in statins. So talking about this, we were already thinking about, well, if we did develop a risk algorithm, where might it tap in? Well, it could potentially tap in here, or actually right up front at this space here. So I'll come back to this notion later on towards the end of the presentation. But just really to talk about the attendance at the NHS health check is actually very variable geographically, because it varies tremendously with socio-demographic group in terms of age, ethnicity, where people are located. And this graph here this little graphical map of England shows you how it varies from about as low as 10% up to as high as 80% in different regions of the country. And attendees' 10-year and lifetime CVD risk is very strongly associated with age. So as we can see, as we get older, so the high 10-year risk estimates increase with age. So we all know that. And often there are also obviously ethnic differences in these risk estimates. But another thing that's quite important in terms of the NHS Core 20, or the government Core 20 initiatives about people who are in the deprived social groups, because amongst those actually attended, those from lower socioeconomic position or most deprived areas of the country tend to have a more complicated risk factor profile. So they tend to have 3 or more risk factors for heart disease and circulatory disease already. And as you move to the least deprived, so they tend to have 3 or more risk factors, and more tend to have potentially just 1 risk factor requiring modification. So what can we do in terms of trying to achieve equity rather than a one-size-fits-all equality? What can we do to try and readdress the balance so that we can get to those individuals so that they do attend for their NHS health check and potentially have interventions that are needed to avoid the consequences of developing the disease or the sequelae of the disease being minimised? And this is something that Michael Marmot referred to as proportionate universalism. It's something we'd all like to strive for, but it's actually quite difficult to achieve universally. But that doesn't mean we shouldn't try. I'm just going to go and talk about the eye straight away and talk about the vascular supply. So it's closely linked to the internal carotid, because that's where the arterial blood supply to the eye comes. So here's the carotid, here's a nerve to the eye. So the eye is an outgrowth of the central nervous system. So the neovascular unit in the eye is very similar to that that's in the brain. And the eye has a very profuse blood supply. And you can visualize the microvasculature of the retina non-invasively. You don't need to do any invasive tests. And maybe some of you already had this done when you've gone to get your eyes examined. If you go for a spectacle check or to check the health of your eye, if you have a history of eye disease, then you may have already had your retina imaged. And I'm just showing you one camera on the side here, which is used to image the retina. And all it has to do is to shine a light through the pupil, which is obviously the aperture, it's a hole, shining the light into the eye to capture the reflected image back, which looks like this. And I'm just going to outline a few structures on the retina. So we have just a very profuse blood supply of arterioles and venules. So the arterioles are generally redder, brighter red in color, and often have a central bright reflex down the middle of the vessel. The venules are wider and darker in color because the deoxygenated blood then goes back to circulatory system. And this is the optic disc. So all the vessels emanate from the optic disc, and the return is via the same pathway down through the optic nerve entrance into the eye. So that's the optic nerve, and on the surface of the retina it's called the optic disc. And this is a right eye, and here is something called the fovea or the macula, which is the avascular zone. So we don't have lots of blood vessels careering across there, because that's the area of the eye that we use for detailed vision and seeing. So if we had blood vessels careering across there, we wouldn't be able to see very easily. The blood vessels would get in the way of our line of sight. But we use all of the retina, all our spatial orientation around our world uses the entire retina, but it's the fovea and macula that we use for things like using the PC, reading and writing and recognizing faces and things like that. So what are we interested in measuring? Well, there's a lot of evidence already been published many years ago about the vascular changes associated with severe hypertension and cardiovascular disease. So things like narrowing of the vessels, nipping of the vessels, sclerosis and things like that. That's actually once disease has already occurred, and they are the sequelae of the disease. So what we're interested in is in trying to find out measures of the vessels that might be important precursors of disease occurrence, so that we can actually predict disease outcomes later in life. So what have we been particularly interested in? Well, there's been a lot of literature out there now already about the width of a vessel and how tortuous it is, or the wiggle, as we would call it, along a vessel. We've also looked at whether, well, does it matter how much of the vascular, how much of the retinal surface area is actually covered by the microvascular tree from the retina? So it's a kind of like an opportunity, I think, to look into the window of the body of microvascular structures elsewhere in the body are probably undergoing similar patterns of change, especially when disease starts occurring. Or does it really matter how variable a vessel is? Certainly in advanced disease, you can get a lot of variation in the vessel along its length. But we were looking would be subtle changes before frank disease has established. So we developed with Kingston University a system called Quartz, which is an fully automated system for extracting the vascular information from a retinal image. And there are several modules, so I'm just going to go through what the modules are. Once the image first starts getting processed, there is a vessel segmentation that is done, but only if images are of past a certain quality standard. And we have a machine learning automated algorithm to assess image quality. It would then extract the vascular tree and then it can then isolate where the optic disc is so that we know whether we're looking at a right eye or a left eye. So this is a right eye. For a left eye, the image would be reversed. The disc would be on the other side. If we're looking just at one image of the eye, centered on the on this area here, the fovea. And then we have a deep learning algorithm to distinguish between arterioles and venules, because we always thought that perhaps they don't behave the same in terms of cardiometabolic risk. Maybe there are differences between how those vessels might respond. And then we have the mapping out of each individual vessel to try and ascertain its subpixel measures of width, tortuosity, the whole surface area of the retina, and also how variable the width of the measurements are along a particular vessel segment. And so far, we've used this algorithm of ours called Quartz on about 100,000 participants, 200,000 retinal images, and segmented out about 11 million retinal vessel segments. And we've concentrated on some large cohorts, and particularly UK Biobank, which I'm sure many of you are already familiar with, EPIC Norfolk, which is one of the European prospective studies into the dietary and lifestyle risk factors of cancer. So this was the Norfolk branch. We validated some of our work in, and we've also done work in Chase and another study called Forever, which is from Copenhagen in Denmark. Now I've gone and put our actual logo here, which is Quartz, which stands for Quantitative Analysis of Retinal Vessel Topology and Size. And this is just to give you a little bit more detail of how granular the information is that we obtain from this image processing system. And then you get an awful lot of information that comes out, and then we have to create these indices of ours of width, of tortuosity, of area, and width variance to try and see if they are predictive of disease occurrence in the future. And what we're trying to move towards now is a more generic system where it can handle different types of images from different types of cameras, which have different levels of resolution or field of view, to try and tap into image quality so that maybe even if there isn't a perfect image like the ones I've shown you, even if you maybe had just one segment, maybe that would provide enough information about some of the measures in that eye. It wouldn't give you the area, but at least it gives you something about the width and tortuosity. So that's another area we'd like to look into. And also I'd like to just emphasize that these images, like the ones I'm showing you here, are obtained from cameras without any pharmacological dilation of the pupil. So there's no what's called mydriasis. So they're just taken as you are. You sit down, take a picture, and that's it. It takes 2 minutes. Probably to set somebody up with their chin on the resin and actually take the image. So we don't require mydriasis. But obviously, if you have other systems, they tend to use mydriasis to get a better vision if there's difficult to see. I'm not going to go through every single number in this flow diagram, but it's literally just to show you that we've used UK Biobank to develop our models, and we have about 66,000 people with good usable images out of a total of around 80,000. And in the circulatory mortality, the analyses are based on about 65,000 people with over 300 circulatory deaths, and the strokes is about over 400, and again, it's nearly 64,000 individuals in about 7 years of follow-up. So there are different exclusion criteria that apply, because I'm going to show you some our results compared to the Framingham stroke risk score. So first of all, just some cross-sectional associations. So retinal vasculometry is a remarkable marker of aging. And the graphs I'm going to show you are all the same in fours. So on the left is the arteriolar vessel measurements of width and tortuosity, and on the other side is the venular width and tortuosity. And it's really just to show you the patterns by deciles of the risk factor of interest. So as age increases, both levels of tortuosity go up, arteriolar width goes down, but venular width goes up. And the power is tremendous in UK Biobank. So these are the p-values, which are just unprecedented, really. So these are really very definitive relationships. And again, with systolic blood pressure, this time both arterioles and venular width reduce is very powerful, especially on the arteriolar side. And again, venular and arteriolar tortuosity goes up. And these are models from what's called an adjusted multi-level models, because we have both eyes to contribute to the analyses, and they are adjusted for age and sex and the relevant decile of the risk factor shown in the graphs. And we published this evidence already. And just to give you a little bit more information about the other different risk markers like BMI and trunk fat percent, again, a very strong venular signal this time for width and tortuosity for both of those graphs, but not much weaker signal, but still there for arteriolar width, declining with increasing levels of these two markers, body fat, body mass index and trunk fat index, but nothing really for arteriolar tortuosity. So that's cross-sectional. It's all very interesting, but it doesn't get us anywhere in terms of risk prediction. So now I'm going to go towards risk prediction. We use UK Biobank to develop our models, and then we validated them in the EPIC Norfolk cohort, which is about 5,000 individuals. And again, these graphs repeat. So on the horizontal axis is the probability that we would predict of a circulatory mortality for individuals. grouped into deciles of risk. And on the vertical axis is what we actually observed in these individuals about 7 years later. If the model was perfect, all our observed and fitted would agree, and they'd all align on the 45-degree line. It's doing pretty well. And these are obviously very low risk, because this 0.01 probability is actually a risk of just 1%. So actually very low risk in UK biobank. It's a very low risk cohort, often called the worried well. And all the prediction model included was the retinal vasculometry measures, age, smoking status, ever had a heart attack or stroke, or do you have diabetes, and are you on any blood pressure medication? So it's meant to be a risk algorithm that we could use for everybody, even if they've had an event already, because it kind of stratifies them in terms of what their risk is today. And the C statistics are akin to areas under the curves, but this is used using cost proportion hazard models. It's not quite an area under the curve, but it's kind of, you can think about that in that if you pick 2 random people of the person that had an event, how many times did that person actually have the higher risk estimate compared to the other one? And so that happens around 75 to 76% of the time. And that's what a C statistic is. So that's actually pretty good, because most of the other algorithms, which I'm sure many folk are familiar with, like SCORE or Q risk, or the I forgot what the other one's called, framework, that's it, framework scores, get values of C statistic in this region across the world, across different cohorts. If we then try and validate it in EPIC, external cohort, who are a decade older and have a much higher risk of an event, the model actually performs quite well again in terms of what the C statistics are and how the observed and predicted risks aligned. It's just that the confidence intervals here are a little bit less precise because EPIC is not such a big cohort. So all the graphs I'm going to show now, I'm going to flick through. It's about our prediction versus what actually happens 7 years later. So this is circulation mortality, looks very good. Oh, I forgot to say, I forgot this was popping up. We published this back in October in the British Journal of Ophthalmology, and we're absolutely delighted that altimetrically it's tracked about nearly 25,000 outputs. I know it's been downloaded, the full paper, about 25,000 times. And compared to other papers published at that time, this is in the top 1 percentile of publications, and it's in the top of all research outputs ever tracked by altimetric. So our team, we're very proud of that as our team. This is for stroke. So I'm just going to flick through. Predicted risk of stroke compares very well with Framingham, which I show on the next slide. So again, the risks aligning very well in the internal validation of our methods. External validation is here. So it's quite remarkable that the C statistics are quite stable across a different cohort that's a decade older with a much higher risk. And I forgot to say that the R statistics, which are a bit higher for circulatory mortality, just a little bit, represent the proportion of the variation in mortality rates that's explained by the algorithm. So it's like a bit like a linear regression R-squared, but it's in terms of explaining variations in survival rates. And that's how much explained by the risk score. Okay, so that's stroke. Very quickly, there's a comparison with Framingham. So again, not to spend a long time on it, but the numbers are very similar. But we're just using an image and a few questions. And this is the Framingham revised stroke risk score. For MI, a little bit weaker, but again, it compares favorably with like the Framingham hard risk score. But this obviously requires blood pressure and a blood sample, which we don't do. So if you were going to do the Framingham one, but we didn't. This was just to do with the retinal image and a few simple questions. If, however, you're going to do Q-risk, it can get quite complicated if you choose to populate all the items in a Q-risk algorithm. So there are over 20 items measuring, not just blood pressure and blood lipid levels. But ours obviously is totally non-invasive, just an image and a few questions. So where are we going to go next? How could we incorporate this somehow? We just take a non-invasive picture of the eye, you get a view of the vasculature, use that to create a risk score. How we could translate that next? Where are we going next? Well, obviously our ideal is what we're trying to do is to reduce the individual person's risks by modification, lifestyle or treatments to eventually prevent disease in the population. So it's reducing risk in the people to prevent disease in the population. Retinal imaging is widely available. There's high street availability. When you go to have your eye test, you to have your eye image, hospital eye clinics, optometric eye practices have these almost pervasively now. But where could we put it? Where could we put a camera like this? Ask a few questions and have an algorithm that punches out a risk score. Perhaps in a GP practice, maybe in the pharmacy, maybe even just outside a supermarket where you get a lot of traffic coming through. Maybe that would be a good way to capture people, to encourage them to have their health assessment done, to encourage for them also to go for their NHS health checks. So it's easy accessible. And as I said, Don't need a blood test, don't need to measure blood pressure, don't need any drugs to dilate their pupil, just a picture and a few questions. At this point, I'd like to stop and thank, obviously, my co-workers. I won't be presenting this work to you if it hadn't been for the fantastic team that I have here at St George's and at Kingston University, and also at Cambridge University, and they are and at UCL now, and Moorfields Eye Hospital. So here is the team here. So Sarah Barman from Kingston and Roshan Walakala, who's been instrumental in actually developing the quartz algorithm with us for 10 years now. Paul Foster is Moorfields Eye Hospital consultant in glaucoma and also at UCL. At the Institute of Ophthalmology. Robert, Shabina and Katie Kaur, I'm very grateful for because they allowed us to access the images from the EPIC Norfolk study, from the Cambridge group, and obviously Peter and David and Chris, who are in the Population Health Research Institute. And I'll take questions, I think, at the end after the next presentation. Is that? Do it now? We could do it now? Okay, happy to take questions now if I haven't overrun. So thank you. I don't know if anyone has any questions. I need to go to the Teams window, don't I? There we go. Expand that like that. Is that okay?
Perfect. Thank you so much, Alicia. It's super clear and perfectly on time as well.
Oh, good.
Thank you. Do we have any questions? Yes.
Thank you for the presentation. Have you looked if your measurements correlate with cholesterol levels?
Not very strongly, actually. Not as strong as with the other risk markers.
So that's what is surprising that when you're comparing with the Framingham score, which includes blood cholesterol levels.
For chronic heart disease, it does, yes.
Yes, so it performs similarly.
Yes, well, maybe Framingham maybe a little bit better, but for the stroke risk score, a Framingham revised stroke risk score, you don't need lipids. But yes, it depends. Framingham has a lot of risk algorithms depending on which particular CHD or hard MI outcome you're looking for. So the equations do vary, but you are right. You always need a blood pressure measurement and you need a lipid level measurement, and you also need, obviously it's a separate risk equation for men and women. There is a signal on the arteriolar side, but it's not as strong as some of these other ones in terms of how they relate to the lipid levels.
So I like the idea of screening people like that very non-invasive method, but that there's a bit of danger that you could sort of dismiss those who have high cholesterol but don't have the eye measurements that you're showing the difference, basically, and you might, say, oh, you are fine, but perhaps they've got something else going on.
I know what you're saying, in that we're not necessarily picking up, we haven't directly shown you whether we're picking up people with high lipids, but the fact of the matter is, I think that the algorithm actually does, if you take the top quintile, you're going to get 60% of the people who in the future actually do suffer an event. So I think that's what's key. It's about remembering, it's not about the cross-sectional measurement of something today, it's about what's happening to these people 7 years later. So it's about, you're talking about cross-sectional associations, which often are interesting, but they don't necessarily translate into what is needed for predicting risk in the future. So for example, even if you look at, I always thought that I must include, must make sure I include in all the risk equations whether people are taking statins or not. But actually, once you took all this other stuff into account, whether somebody was on a statin or not, for example, didn't have any extra discriminatory capacity in terms of future risk of an event. And that's not to be a surprise, because obviously once you're on a statin, you're reducing people's risk already, because that's why they're on a statin. But although cholesterol is one of the, is a very important modifiable risk factor, it's not the only risk factor, because obviously this is a multifactorial disease, but it's the one that we can modify very well by using, 40 milligrams of simvastatin or atorvastatin.
Thank you, Alicia. I don't know if this question will come out right, but actually, in terms of predicting the likelihood of cardiovascular disease, whatever shape it may be, have you thought about that sort of next stage in terms of the messaging that somebody would receive?
Yeah, absolutely.
Once they get that information, because it's, you've never had something from a GP saying your cholesterol is high. It's literally a text message on the phone. What does that recipient do with that information? Because it's all about the next stage.
Absolutely.
And how this goes forward.
Now, I'm really glad you've mentioned that, actually, Fiona, because it's something we've been talking about quite a lot, in that the whole problem is, well, we can understand risk, especially when you're doing research, we can understand what risk means. But often for the individual, it's very difficult. And I probably should have highlighted more strongly that we were talking about 5-year risk, just 5, because we only had 7 years of follow-up in biobank, so 5 years. But often when you go for risk assessment, it's your 10-year risk. And I often think that seems so far away from where I am today. We've had quite a lot of conversations about this. In fact, we're thinking of working up a specific project about how would you communicate risk to people so that it's effective, so that they actually do something about it, or they actually understand what it means. So one of the endocrinologists, I also do quite a bit on AI and diabetic eye screening, and we were talking about this risk algorithms in terms of patients that attend for their eye screening exam at the North East London screening service. And the endocrinologist says he hates Q risk. He says it doesn't mean anything to people telling them their risk is 5% in 10 years. They'll go like, so what? And smiley faces, he says, I don't know why we have those smiley faces. So people have a different view. Some people, for us, I think smiley faces are great. We like them, we can see them. But I'm not saying this is what we should do, but he said we should think about it completely differently. How about if I tell you, you may not see your kids grow up, or you may not see your grandchildren, or you may not, that's the seriousness of what you've got. And that's quite drastic to say something like that. I'm not saying that we should say that, but clearly what we like to use in terms of risk reporting for us, in terms of assessing how good different systems might be or preventative strategies and interventions might be, is not what we should be using when we're talking to people in understanding their risk and actually then choosing to want to make a change.
Message may be better delivered by somebody else as well.
Yes, yeah, absolutely.
Somebody from the same ethnic group, the same, gender, thinking about somebody that's been through this process already. So, yeah.
Yeah, sort of lived experiences type of individuals. Yeah, no, thank you very much. Good point. So, I don't know if there's one.
We've got 2 online actually, so perhaps we'll go to Irina.
Hi, can you hear me?
Yes, I can hear you.
Okay, thank you very much. Fascinating from such a complex situation to something, strikingly simple, which I know is not. Okay, I was wondering about the dynamics of this process, for instance. So if your data allow assessing the timing from the markers detection to the disease development, and whether wouldn't that be a more powerful analysis? I'm just asking. I appreciate that you have shown the baseline and 10 years time, but during these 10 years, that would have developed at any point in time.
Are you thinking about time updated input into like a prediction model that is time updated? Yeah, we haven't done that because we just have UK Biobank just has that baseline wonderful measurement that it gives you all those measures, and the repeats are they're not repeats on the eye folk. They're repeats in new people, but repeats. So our subset actually only have everything done once in this large cohort. But you're right, you could do. There are these time-updated clinical prediction models. There's quite a lot of work on that actually going on now, and that you could update your models. But another way of looking at it is, I kind of, my gut feeling, and I might be wrong obviously, is that I think the eye has a window of opportunity. And maybe 10 years is too far away, but maybe 5 years is sensible in terms of what's going on in the eye and in terms of it being accurate. I haven't tested that yet because I need more follow-up to sort of show, well, actually 10 years is too far away from when you've taken the image. So that's another, I thought that's what you're asking. Maybe you're asking both those things.
Yeah. Thank you very much. Fascinating. Lovely. Thank you.
Thank you very much.
And we've got time for Jeremy as well.
Hi there.
Hi.
Presentation. Thank you. I think my question is a little bit similar to what has been asked, which is whether you have longitudinal data in individuals to show whether these markers change at the individual level over time, sensitive that change is, and whether it's useful for biomarker, and whether that intervene, for example, you aggressively lower blood pressure or have an entry, you could show that the trajectory on the retinal biomarker actually changes.
Yes, it could be that. Unfortunately, we don't have the data available to answer that question. But you're right, it may well be there's something very interesting about either updating the risk algorithm with updated measurements or looking at someone's history in terms of potentially how they've changed over the recent past. So we haven't been able to do that, although that is something that we are thinking of doing in a diabetes cohort, because we're now quite like to sort of translate our models, see how stable they might be in individuals that attend for diabetic eye screening. Because you've got an image, they're already there, we can easily tap into that. And we're linking that with primary and sus data and secondary care, primary secondary care data. So we are hoping to look at what someone's recent past might have been like and what their image is like, because those two things together might inform the future better, potentially. I don't know, but it's definitely food for thought. Thank you for your questions.
Brilliant. Thank you so much for your questions, everyone. Thank you, Alicia.
Thank you.
Fantastic talk. Very exciting. So our second speaker is Michael Papadakis. I hope I said that incorrectly. And we're going to talk about cardiac sudden death. Thank you so much.
Yes, thank you very much. We'll stay in the field of cardiovascular prevention. I'm referring to a slightly younger group with my talk. Obviously, a bit difficult to follow Alicia's talk, but I'll report to you essentially the experience that we had with a large screening program. One of the questions I was going to ask is whether you looked at a younger age group, but with your response in terms of that you're thinking about a 5-year and you're not sure if it's predictive for 10, 15, 20 years, maybe that answers the question. I agree that communicating risk is extremely challenging, and I find it extremely challenging in younger individuals as well, because we like to start at 50 or 60, but maybe that's a bit too late. And the problem is that if you've got a 30-year-old with hypertension, hyperlipidemia, familial hypercholesterolemia, so on and so forth, based on the age alone, the 10-year risk is going to be low, and that's where the lifetime risk with its pros and cons comes into play as well. So what I'll report is a cardiac screening of young individuals, and by young, we mean 35 or younger. The age group I refer to is 14 to 35. And I'll report on the experience that we've got from a large screening program that we're running. And maybe that's a group that you can potentially use as well to test your theory in younger individuals. My conflict of interest is that I do collaborate very closely with a charity called Cardiac Risk in the Young that support pre-participation support cardiac screening of young individuals in order to identify congenital or inherited cardiac conditions. So the inspiration for the screening program comes from a sudden cardiac death that can affect younger individuals. Usually you will hear about sudden cardiac death in a young individual when it's a major sportsman that gets affected, and you may have seen in BBC recently talking about the son of LeBron James, Bronny James, who had a cardiac arrest while playing basketball. But the reality is that all young individuals can be affected by congenital and inherited cardiac conditions that can predispose to malignant arrhythmias and sudden cardiac death, but they usually don't see the news. Our estimate is about 600 deaths. You will see from our data that it's probably more than that in the United Kingdom in this particular age group per year, which comes to about 12 young cardiac deaths per week. Now, if someone goes and looks at the incidence of sudden cardiac death in young individuals, you get a highly variable incident that can go from anything 1 in 8,000 person years to 1 in 200,000 person years. And there are lots of reasons why there is such a variability. And although, yes, there will be differences based on the population someone look at, these are all young individuals, but a lot of it comes from the methodology that people use in order to assess the incidence of sudden cardiac death. And part of it as well is the fact that in a lot of them, cardiac arrest do not count. So a survival of sudden cardiac arrest won't make it to the registry for sudden cardiac death in young individuals. And a good example is Christian Eriksen, who had a cardiac arrest, but due to the emergency response planning, he was able to survive it, and he's back playing football for Manchester United. And the example I just said about Bronny James, who was resuscitated during a basketball game, and hopefully he'll make a good recovery. Now, in terms of the causes of sudden cardiac death in young individuals, and that's part of the challenge that we're facing in terms of screening as well, is that it's not caused by a single condition, but it's caused by a group of conditions. So we've got inherited cardiac conditions such as cardiomyopathies, and this is a post-mortem sample of a very thick heart with significant hypertrophy from hypertrophic cardiomyopathy. We've got other cardiomyopathies such as arrhythmogenic cardiomyopathy or dilated cardiomyopathy. We've got the ion channelopathies, the electrical faults of the heart, and you may have heard of long QT syndrome, Brugada syndrome. And then we've got connective tissue diseases, and a good example will be aortopathies and Marfan syndrome. We've got congenital heart diseases, and in the young, it will be the coronary arteries, but not because of atheroma. It will be predominantly because of an anomalous origin. So your coronary arteries come from the wrong side and may get squeezed, or the blood flow may be compromised, particularly during exercise. And then we've got accessory pathways, and you may have heard of Wolff-Parkinson-White syndrome, where essentially you've got an extra pathway communication between your atria and your ventricle, which can predispose to arrhythmias and occasionally to sudden cardiac death. And this is an example of an anomalous coronary artery. And then we've got acquired conditions, and this is an MRI scan. The black is here is the muscle, and the white is lots of inflammation and fibrosis within that heart muscle due to infection with myocarditis. And myocarditis was a very popular subject, particularly during the COVID-19 pandemic, for right and wrong reasons. And then we can have obviously absence of heart disease. A commotio cordis is a good example, where you get a hit on the chest, and that hit comes on the relaxation of your heart, on the repolarization. And if that happens, then it can push your heart into ventricular fibrillation. If you get resuscitated early, you may survive it. And other things like drugs or substance abuse. Now, in terms of preventing sudden cardiac death in young individuals, there are certain things that we can do. One, and the obvious one, is if you've got someone who is symptomatic, has cardiac symptoms or family history you're worried about, then they should be evaluated by a specialist, and we all agree on that. Emergency response planning can definitely be very effective. If you manage to get a defibrillator there by 5 minutes, there is up to 80% chance that that individual may have a meaningful survival of that cardiac arrest. But you need to have a whole organized system around it, if it's in a stadium, if it's a station or in the community. And then for families who have experienced a sudden cardiac death that an inherited cause is suspected, what we do in our clinics, we bring them for clinical as well as genetic evaluation and try and see if we can identify the cause of the sudden cardiac death of the loved one by identifying condition in their first-degree relatives, or subject the post-mortem sample of the deceased to genetic testing for variants that are associated with such conditions. Now, the problem with looking at it in symptomatic individuals or individuals who had an episode of family history is that the majority of the sudden cardiac arrest will be actually the first presentation. So the estimate is that about 80% of sudden cardiac arrest, sudden cardiac death in young individuals will not necessarily have pre-existing symptoms or meaningful symptoms that may raise suspicion or a family history. So in the context of having a pre-existing condition and sudden cardiac death being the first presentation, that's where cardiac screening comes into play. Now, the protocol that it's usually recommended, and it started from young competitive athletes, but here in the United Kingdom, we extend it to young individuals, irrespective of athletic activity, is that of a health questionnaire that you try to assess symptoms and family history, physical examination, and the key being the 12-lead ECG. And in our screening program, we rely predominantly on the health questionnaire, the 12-lead ECG. And the 12-lead ECG is a useful screening tool because it is the tool that diagnoses the accessory pathways, the ion channel diseases, and conduction issues with the electrical wiring of your heart. And it can also be abnormal in a significant proportion of structural diseases such as hypertrophic cardiomyopathy and arrhythmogenic cardiomyopathy, even before you're able to recognize it on an echocardiogram or a cardiac MRI. And the point is that if you identify an individual, then you refer them for further evaluation. And depending on whether you make a diagnosis or not, you can implement the necessary lifestyle changes, including exercise, medication, or give them appropriate protection with a pacemaker or a defibrillator. Is there any solid evidence that cardiac screening necessarily works? The answer is Probably not. That's the best study that there has been out there. Part of the issue is that we're discussing about risk and incidence of sudden cardiac death. And here you've got the study by Domenico Corrado in the Italian group, where they have been screening since the 1970s, essentially, exactly the protocol that I showed to you. And they try to track in an observational fashion, however, what happened to their athletic incidence of sudden cardiac death compared to their general population. And they saw a reduction from about 4 per 100,000 per year to about 1 per 100,000 per year. But beyond that, there is nothing else really out there. And other concerns relating to cardiac screening, I'll say there are plenty. The relatively low incidence of sudden cardiac death makes it, you need a large numbers to detect the cases and to prevent sudden cardiac death. There are concerns about how effective the screening tools are in terms of false positives and false negatives, and I'll come to that in a second. There are issues relating to the availability of expertise as well as costs, particularly in terms of driving people to secondary evaluation. And the question was asked, you know, if the scan comes back as negative, then what do you do with how do you follow that up? Management of individuals identified with a condition, because it's not one, it's multiple conditions, and as I said, the available expertise. So the way we do it here with cardiac risk in the young is that we go everywhere, basically. So it can be a hospital. We used to give them here at St. George at the outpatient department before the pandemic came along. We go to stadiums, we go to schools. We have a van that people can come and have their screening and go and try and make it as easy as possible. It refers to 14 to 35 years old. Screening is done throughout the United Kingdom. The nominal price is £50 per screening individuals, but usually what happens is a family who has lost someone, they will do a fundraise, they will collect the money, and then they will open 100 slots, and then you'll get people who register in. And essentially what they'll do, they'll fill a questionnaire, which is their personal symptoms, the family history, their exercise regime. They will have a 12-lead ECG, and then they will have a consultation with our cardiologist. And if necessary, we can proceed to a transthoracic echocardiogram, which we will have there available on the spot. And in terms of the individuals that we screen per year, prior to COVID, we were close to 35,000 young individuals per year throughout the United Kingdom. So obviously that gives you a rich data set as well in terms of their personal history, their family history, and their ECG. Obviously COVID hit and everything stopped, and now we're almost back to about 30,000. And our main limiting factor is essentially because there is a lot of demand for it, but it is the fellows, the cardiologist who's available in order to be able to perform that consultation, look at the health questionnaire and look at the 12-lead ECG. Now, we have been able to produce quite a few papers and data that have led to optimization of the ECG criteria that we use and gradual reduction of the false positives, if you want, people who ask to go for secondary evaluation, but we never identify anything. And that has led to devising the current ECG criteria, which we'll call them the international ECG criteria, that have been in use since 2017, and has led also to significant reduction in terms of cost of the screening program by around 20%, by predominantly reducing the secondary evaluation that is necessary as fewer people get referred. And we have published some of our experience, and this is from a group of people of about 25,000 individuals in terms of our experience with screening program. But this is based predominantly on the individuals who were flagged as abnormal by the screening program, and then try to see what happened to them once they went for secondary evaluation and how many of them were diagnosed. So in terms of evidence gaps, what we wanted to achieve with the study is to look at the continued uncertainty over the incidence of sudden cardiac death. And you may say, well, you look at the incidence of sudden cardiac death based on your screening program. Well, yes, we will. It will probably reflect the absolute minimum, because some of those individuals will have been screened and excluded already, or have had some sort of intervention, but there is no doubt that there is no screening tool that is going to detect all individuals with cardiac disease. And definitely that's not the ECG as well. So we thought that we would look at the incidence of sudden cardiac death in the population that was involved in the cardiac screening program, and also look at our the conditions that we identify in a large cohort of more than 100,000 individuals, but very importantly also look at the false negatives that we have not done before in terms of follow-up individuals, so go back to individuals that were identified as normal by our screening program. So those were our objectives, and this is our fellow Hamish McLachlan, who collected all that data and that did the association and correlation in order to try and get the outcomes to determine the diagnostic yield, look at the false negatives, and report on the incidence of sudden cardiac death and sudden cardiac arrest. So what we've got a population of more than 104,000 young individuals between the ages of 14 to 35 who were screened between 2008 and 2018. And essentially, they were screened with the protocol that I've just suggested. They had the health questionnaire, the ECG, the cardiology consultation, if necessary, an echo, and then they got an all-clear result or requirement for further evaluation because we were diagnosed or we were suspecting a cardiac condition. In terms of getting follow-ups, we had three sources. So we linked data with NHS Digital and the Office of National Statistics in terms of outcomes. There are some limitations to add in terms you'll get very good data in terms of cardiac arrest, definitely death, hospital admissions or any procedures involving hospital admissions. The outpatient data, you really need to go to, you'll get some, but you need to go to the GP databases, which we haven't done for the time being. The other thing we did, however, is we emailed people directly as part of their consent that they had during the screening program, and they responded to, in order to respond to us and let us know what the outcome was since they were screened. And the final thing is that we've got families and individuals who very kindly, despite getting particularly if it's a negative screen, if something happens to them, then they come back directly to the charity to let us know that something happened. Most of the time is in a well-meant and well-nurtured word in terms of they want things to get better and improve rather to come to complain that you told us that the screen was negative, but something happened to myself or was diagnosed with a condition, okay? I won't stay on this for a long time because it's a bit complicated, but essentially out of the 104,000 individuals, we're able to match 90% with the ONS HES data, okay? And we were also able to get about 20 to 25,000 individuals who had a response directly to our email through the questionnaire. So overall, we had an outcome in about 102,000 individuals, but no data, either questionnaire or unable to match them to the ONS HES data. Now, remember that these individuals get screened once, so this is not a repetitive screening program because the question was asked as well earlier to Alicia in terms of whether there is value of repeating the test. We have not been doing that. Others have and have shown a benefit. And the mean follow-up from the time of screening of the individual to the time that we collected data, we got a response, was about 6.2 years. So that's more than 600,000 person years of follow-up. Now, in terms of our results, if we look at the things that we roughly know already, out of the 104,000 individuals, 2.5% were identified as abnormal by our screening, okay? And they were referred for further investigations, and 446 were identified with a cardiac condition, okay? I've separated them to major and minor cardiac conditions. What do I mean by that? Major would be a cardiomyopathy that is clearly associated with sudden cardiac death. Minor may be something like mitral valve prolapse or bicuspid aortic valve, which can cause issues, but it's usually not associated directly with sudden cardiac death. And the point to make here is, the first point to make is that out of those individuals, so you can see that 0.27% were identified with a major condition, and 40% of them had a major intervention. What do I mean by major intervention? All of them will get lifestyle, they may get medication as well. I'm talking about heart interventions, having an ablation for your pathway, having a defibrillator, a couple of them who had a heart transplant, so on and so forth, okay? The other thing I wanted to highlight, because I said minor cardiac conditions, that about 30% of even them had a significant cardiac intervention in terms of managing the valve, for example, closing a PFO or an interatrial communication and AST, so on and so forth. So maybe they're not as benign as we usually think. But let's look at the other side. So those are the individuals that we clear, 97.5%. And from them, based on the data during follow-up, 222 were identified with a cardiac condition and 86 with a major cardiac condition, okay? Some of them had cardiomyopathies, some of them had ion channelopathies, some of them experienced, 29 individuals experienced sudden cardiac arrest and sudden cardiac death, despite the fact that they were cleared by screening, and a similar proportion was identified with minor cardiac conditions. And the point to highlight as well that there was, on average, a 4-year gap between the clear screening and getting a condition diagnosed or identified. Now, in terms of the all-cause mortality, we had 87 deaths in that particular population. You'll see that cardiac mortality, it's a bit ahead from cancer in terms of natural causes of sudden death, or death on those individuals, and the rest are accident, suicide, and some drug overdoses as well. Now, if we look at the cardiac causes, we had 35 deaths or cardiac arrest. You will see the point I was trying to make earlier, that cardiac arrest and sudden cardiac death are almost 50-50. So if you don't count the cardiac arrest in your registries, then you'll get half the incidence of sudden cardiac death. And of the conditions identified, there was a proportion of cardiomyopathies, particularly rhythmogenic cardiomyopathy and dilated cardiomyopathy. You'll note there is no hypertrophic cardiomyopathy, which identified and managed a few of them. Then there was a big proportion of what will be predominantly electrical faults of the heart, so ion channelopathies, and there were a few in terms of aortic dissections, acute myocardial infarction, and other conditions. Now, if we look at the incidence of sudden cardiac arrest and sudden cardiac death based on our data, it's 1 in 7, almost 1 in 18,000 person years. So it falls on the high range of the initial table I showed you initially. Males, more frequent than females, a ratio of 3 to 1, and that's not surprising. Depending on the study you look, they've quoted up to ratios of 9 to 1. We didn't find any significant difference in terms of athletic individuals, elite athletes, compared to the general population, which probably argues for the fact that if we're going to do it, we probably need to do it for every young individual rather than the elite athletes alone. Now, this is the table I've shown you already, and the only thing I wanted to highlight is those sudden cardiac arrests and sudden cardiac deaths. 29 were normal by the screening program, so were missed. But there were a couple who were referred, but they never followed up with the referral, and they had a cardiac arrest or cardiac death. There were a couple who followed up with the referral. They were seen, they were discharged, and then they had a cardiac arrest, which again may speak to the challenges or may speak to the expertise as well that are required. And there were even a couple who were diagnosed with a condition, and then they had a cardiac arrest. And obviously, we have to recognize that I've got patients with hypertrophic cardiomyopathy in my clinic who had a cardiac arrest while I consider them at low risk and didn't put a defibrillator in them. So that will always remain a challenge. Just briefly on this table, the only thing I wanted to highlight that very similar to what I tell you about diagnosing a condition, the average mean time for cardiac arrest was about 4 years after the initial screening. So there is a lag there. And the other thing I want to highlight is that the majority of those cardiac arrests and sudden cardiac deaths, they were not during sports, they were during rest, and they were during sleep as well, okay? And this highlights the challenge of organizing emergency response planning outside the context of a big stadium in order to get to them by 5 minutes and administer defibrillation, okay? Now, in terms of the false negatives, It's not surprising because we know the limitations of the ECG. It will never detect coronary artery anomalies. They don't give you any ECG signs. They may give you some symptoms. It will not detect all cardiomyopathies. Obviously, we have to also accept that there are some limitations in our understanding of the conditions that cause sudden cardiac arrest, sudden cardiac death at a young age, and we're still learning about it. A good example from this study is the fact that there was a large proportion that we call them SADs. What does SADs mean? It means you have a cardiac arrest, you die, they do a full postmortem, including a cardiac postmortem, and everything looks normal. We screen your first-degree family relatives, and we don't identify an inherited cardiac condition, so we're not any further forward as to the exact cause of that sudden cardiac death, and we call it SADS, which is sudden arrhythmic death syndrome, a very descriptive term, essentially. And normal findings can also be explained variation in test interpretation. We tested that, and we didn't really miss any ECGs. So we got two experts who have not been involved with the screening program to look at the ECGs of all those 35 individuals, and if anything, they called fewer as abnormal than what our screening doctors had done. The other thing, of course, to consider is what I said before, that this is a one-off screening program, okay? So you may screen someone at the age of 14. We know that those conditions have a degree of penetrance. So hypertrophic cardiomyopathy can develop at the age 15, 16, 17, or 18. And we didn't screen them again to see if they have developed anything. And obviously, that is a limitation. And there are studies now. There is again from Domenico Corrado, who highlights that if you do regular screenings, you may increase your diagnostic yield up to threefold in with this context. And here I've just gave you an example. I don't know how many ECGs you've read before, but if you look at it, you'll see on this side that those T waves look up and upright, while here they've gone below the baseline and they're very abnormal. And this is an individual who had a normal screening initially, and then he was diagnosed with hypertrophic cardiomyopathy, and you can see how his ECG has changed. And in terms of looking at the accuracy of the screening test, based on our data for identifying a major cardiac condition, gave you a sensitivity to about 77% with a good specificity, a positive predictive value of 10%, which is roughly what other screenings have produced, and a negative predictive value of about 99.9%. So in terms of limitations, obviously, the results represent a minimum incidence of sudden cardiac death or sudden cardiac death, because this is already a screened population that you have excluded a number of individuals, so raises questions as to what the true incidence of sudden cardiac arrest and sudden cardiac death is, and whether people have been underestimating, including ourselves. Because if you look at the Office of National Statistics data that I published as a fellow, looking at death certificates, the quota was getting about 2 per 100,000 rather than 5 and 6 per 100,000 per year that we're getting here. So that's something we need to consider. And obviously, in this study, we included sudden cardiac arrest, which I think is what should be done. So in conclusion, diseases associated with sudden cardiac arrest, sudden cardiac death are identified in about 0.3%, so almost 1 in 300 participants. And you've got the possibility potentially based on this study to increase the yield if you do repeat screenings. And 40% of them receive potentially life-saving intervention based on our results. The incidence is exactly as I said, it's 5.6 per 100,000 person years, which halves if you take the sudden cardiac arrest that were resuscitated out. And most of them were due to confirmed or presumed electrical activities, which puts us a bit away from the thinking that we had previously that it's predominantly cardiomyopathies that are causing the problem. And I think I'll leave it at that because I took already a lot of your time. Thank you very much.
Thank you very much, Michael. We've probably got time for one question. Yes.
I've heard a lot of cardiologists talking about a lot of things like these smart watches, Apple watches, and a lot of cardiologists say that actually it's actually very good, given it's essentially what, a 1 lead ECG. But has anyone sort of looked at that? I appreciate obviously one is a lot less than 12, but have they been shown to have any bearing on acting as the sort of screening for this kind of thing at all?
Not for the time. So they've tried Apple Watches, for example, for detection of atrial fibrillation, and it's a pretty good tool. Yeah. I suspect the way technology and AI is moving, that we'll end up in a situation that our data in terms of our vitals, our heart rate, my heart rate variation, our ECG will be monitored 24/7, and then we'll try and identify who is at increased risk of a cardiovascular event. However, it's important to know that we're not there yet, and also it's important to know that we've got lots of challenges. And I'll give you a prime example. Because we've got those monitoring devices, we've got patches that we can stick on for a week, 14 days, that does an ECG, you've got your Apple Watch. We did a study looking at hypertrophic cardiomyopathy patients. Now, based on our current risk stratification protocols, which used to be on a 24-hour ECG monitor, showing an arrhythmia, and then putting you at increased risk, if you put the same calculator with a 14-day ECG monitor, then you start implanting ICDs, right, left, and center, because you consider them at high risk. So that highlights the challenge that we've got, because we need to be able to properly interpret all that data that we're going to receive with devices like the ones you mentioned.
Thank you.
Wonderful. Thank you so
very
much. Thank you, Michael. Thank you, Alicia. Please do come and join us for cake. And if not, we'll have a break for August, and we'll see you in September.
Thank you.
Thanks, Julie.
Thank you.
Yeah.
I'm